extracting valuable feedback from focus groups and interviews. So a few logistics before we get started. Our webinar today is being recorded and a link will be available on the Expecting Health YouTube channel after the conclusion of today's webinar. If you have questions during the presentations, please submit them in the chat box and we'll save them for the Q&A period at the end of today's webinar. If you need IT or technical assistance, use the chat box to communicate directly with Jamie or I, and we will assist you with that. Unfortunately, today we aren't able to have live captioning, but when we send around the recording of the webinar, there will be a transcript to accompany that. So for today's agenda, we have two wonderful presentations, and the first one will be Norma-Jean Simon talking about the value of cognitive pretesting and newborn screening example. And she will be followed by Lori Williamson Dean from the Heartland Regional Genetics Network talking about their Hispanic Access Project. And then, as I mentioned, at the end, we'll have a Q&A session. So this education and engagement series is supported in part by Applied Therapeutics. So we want to say thank you to them for that. And as you may know already, it's Newborn Screening Awareness Month. So we have a lot of events going on. And one of those is our last engagement and education session next week on September 23rd at the same time, same place. And we will be talking about Get the Narrative, Storytelling Through Surveying. And we will have Natasha Bonham and Allison Wood talking about that next week. So if you're available, make sure to tune in again. And we also have our newborn screening Twitter chat tomorrow from 2 p.m. Eastern time. And if you're available, we would love to have you join in on the Twitter chat and answer some questions about newborn screening with us. So without further ado, I will introduce our two speakers. Our first speaker is Norma-Jean Simon. She is an experienced clinical and behavioral researcher, and Norma-Jean has partnered with research investigators on a variety of topics, including the development of surveys and qualitative interviews in the domain of newborn screening. So following Norma-Jean, we will have Lori, and Lori is currently an assistant professor at the College of Health Professions at the University of Arkansas for Medical Sciences, where she teaches and mentors genetic counseling graduate students and serves as the co-director of the Heartland Regional Genetics Network. And she has been with the Heartland RGN since its inception in 2004. And she's going to tell us a little bit about the great work they've done in Heartland a little bit later. So first, I will turn it over to Norma-Jean for her presentation.
Great, thank you. So as Brianne mentioned, today we're going to be talking about the value of cognitive pretesting through an example of newborn screening. Next slide. So the objectives that I'm hoping to get across today are to demonstrate the utility of cognitive pretest interviewing as a means of improving survey validity, and also describing briefly some of the results of our cognitive pretest interviews on a survey specifically about parents' experiences receiving newborn screening results. Next slide. So just a little bit of background. Surveys are commonly used to gather a range of data on newborn screening programs. Some surveys that I've involved with previously are within the domain of newborn screening are cost surveys for economic evaluation. This is trying to understand the household or family costs that are associated with certain inherited or genetic conditions, and those monetary, non-monetary costs that might spill over to the family. Also understanding public values or perceptions of newborn screening. I've also been involved in surveys for newborn screening processes. So these are at the lab and the hospital level. And then of course today in red are parent and family experiences, which is the topic for today. So the survey that I'm going to be talking about today comes out of a project called Unresolved Issues in Newborn Screening, Quantifying the Harms of False Positive Results, which is led by Beth Tarini at Children's National. And that study aims to determine the scope and magnitude of harms that may be associated with newborn screening, and also identifying parent and child factors that may be associated with harm. So just to give you a little bit of background and perspective. Next slide. So this study is going to be a prospective cohort study. We're going to be surveying parents of children that have both normal and false positive results. So it is a large swath of parents with newborns. And our primary survey that I'm going to be talking about today is something that we've referred to as our initial survey. It covers multiple domains. It's the very first survey that parents are invited to take upon consenting and successful recruitment into our study. So that study includes questions about child health and well-being, questions regarding pregnancy and delivery experiences, newborn screening experiences, both newborn testing in the hospital as well as the receipt of newborn screening results, parental mental health domains and questions, as well as family demographics that are common on lots of surveys. So the study itself also includes a repeating battery of validated measures that parents will be given every 6 months until the child is 2 years. And we did cognitive pretesting heavily focused on the initial survey, but we also did a little bit of cognitive pretesting on this validated battery of surveys. Next slide. So this presented a challenge for us, putting together this initial survey. So it was a brand new survey. It covers a lot of different domains. We used validated measures where possible, but we really were starting the survey more or less from scratch. And one of the challenges that we do have with the survey is that we're asking parents to recall medical events. So you have the potential for a lot of medical jargon within the survey itself that you have to navigate. So being intentional about plain language definitions. And then, of course, we also want to get a deep dive or have some really in-depth questions regarding newborn screening testing and communication experiences. And we know based on our own previous experiences that receiving newborn screening results can vary state to state and program to program. So we really wanted to understand how to capture that best. Next slide. So in order to understand how to capture that, we did cognitive pretest interviewing. And this is an evidence-based qualitative method specifically designed to investigate whether a survey question satisfies its intended purpose. Next slide. And why do we do cognitive pretest interviewing? It's to really understand the construct validity of our survey questions and our survey measures. This is to help us identify difficulties that respondents may experience in trying to answer one of the survey questions that we have. And it also allows us to identify what parents, for our survey in particular, what experiences they're thinking about when they're answering our survey questions, and both experiences that we want to capture, as well as those experiences that we don't want to capture. So it really allows us to see whether or not we are truly capturing what we're intending to capture with our survey questions. The other reason that we do it is to understand comparability. So this is to ensure that our survey questions are still relevant and salient across different cultures and different maybe socio-demographic groups. And in testing this, it also helps us identify our own biases or our undisclosed assumptions that went into creating the survey. And then finally, the cognitive pretest interviews are really helpful for helping us inform analysis interpretation, just so that we have an understanding of how our survey population is interacting with our survey. Next slide. So when we start cognitive pretesting, the first thing that we do is we identify questions that we think might be problematic or questions that we really want to test up front. So our cognitive pretesting priorities were the following for this initial survey that we put together. So we wanted to focus first on survey flow and ease. Since this was a brand new survey, we had a lot of domains. We wanted to make sure the order that we put those domains in made sense. We also wanted to get an understanding of how our parents and families were understanding medical procedures and the medical jargon that we had in the survey. And then we also wanted to focus on newborn screening testing, those experiences, and making sure our questions were reflective of capturing the experiences that all of our families could have, as well as newborn screening communication. Next slide. So essentially, this is really what the survey draft development looked like. So we started with a very rough draft in June of 2019. The project team has a number of experts that have been assembled by our PI, Beth Turini, and we put together the survey. We threw it into the validated measures that we could, and then we had all of our experts take a look at it, give feedback, and we assembled what we thought was a good draft. So that took actually a couple of months. We also programmed the survey online so that we had a platform to test the survey. And then about October of 2019, we actually began cognitive pretest interviews with families. And again, we focused on flow and jargon first, And then we moved into newborn screening testing and newborn screening communication. And I also want to point out that through this, as we're pretesting, some other areas may have been identified or focused on just due to our cognitive pretest with families. So next slide. So now I'm going to go through, how we recruited families and then how we actually proceeded with the interviews. So the first thing that you want to do when you're cognitive interviewing is select participants with a focus on the questions that you want to pretest. So for us and for our study, we chose a convenient sample of parents with a wide range of newborn screening results. We really felt that our survey is intended to capture a broad swath of parents with newborns. The majority of parents with newborns are going to have normal results. We really thought we could cast a wide net, and anybody who had a newborn child or a child born within the last 2 years, we thought could help inform our survey development. So we started first with initial cognitive pretest among staff contacts. So those are people that people on the project team knew, and we reached out to them and asked if they'd be willing to review the survey with us. That's helpful on a couple of levels because it also helps us refine our interview guide, particularly if it's among a couple of people that it feels trusted to get feedback. So all of our parents were, like I said, parents of children less than 2 years of age. And it happened to be in our first set of cognitive pretests that all of those results were normal. And then subsequent cognitive pretests, we targeted from cooperating clinics that we work with. And we specifically tried to recruit false positive parents because we know that capturing their experiences are very important for the study. And there are fewer in terms of false positive parents in terms of our entire population that we're surveying. But we were not successful in recruiting a lot of false positive parents. So we supplemented them with true positive parents who may have a similar experience, particularly with follow-up testing. Next slide. And then we proceeded with after we've identified the person, we recruited them, asked them if they wanted to participate in an interview with us. And those interviews can take place in person or by phone. We conducted all of ours by phone, mostly in the evening and weekend hours to accommodate parent schedules. And then there are two different ways in which we proceeded with pretesting the survey. The first handful of pretests, we review the survey one-on-one with the participant, and they actually take it in real time with us. And that way we're able to prompt in real time, we're able to see where they're hesitating on questions, and we're able to really ask what they're thinking about in the moment. And then for the second batch of cognitive pretests, we also had parents take the survey in advance, and then we did targeted probes on questions that we were really focusing on getting right. And this helps basically balance time. And of course, to review an entire survey from start to finish can take quite a long time. And we really wanted to make sure our cognitive pretests were about 60 minutes to be mindful of the time of our parents and families. And usually our pretests range from 45 to 90 minutes, depending on the interviewee. Next. And then all of our interviews are guided by semi-structured scriptive questions. So this is just a screenshot of the first 2 pages of our interview guide. You can see that it is heavily scripted. And then in bolding, you'll see basically our prompts. And our prompts can be, next slide. They can be both open-ended and targeted. So here are a couple examples of the open-ended questions. So we go through the survey kind of section by domain, and we always ask, what was your overall impression of this section? Were there any questions you would change? Are there any questions you weren't sure how to answer? Are there any questions that had response categories that you felt like you needed but weren't there? And then for the newborn screening section in particular, we start off with, when we introduce newborn screening in this section, what were you thinking about? And we actually just get them to really tell us about their newborn screening experience. Next slide. And then we have targeted questions. So some of our targeted questions were, when we refer to the newborn blood spot or heel prick test, do you remember that test being done in the hospital? Would you call this test something other than the newborn blood spot or heel prick test? Which of these 2 names, newborn blood spot or heel prick test, sounds most familiar to you? And this, of course, is trying to test the language so that we know that we're jogging their memory appropriately for the test that we're wanting them to answer questions about. And then in your opinion, is there a difference between being explained the newborn screening test and being told the newborn screening test? And this is an area that we focus on specifically because we were getting information from parents that they were told and they were answering yes, that they knew about the newborn screening, but when we were actually interviewing them and understanding their experience, in their interviews, they were revealing that they really knew very little about what was occurring in the hospital. So we tried to understand how we could best phrase our question for them to answer. Did they basically, did they know about the newborn screening test in the hospital itself? Next slide. And then after we did the cognitive interviews, we moved on to analysis and revision. And for analysis and revision, you're basically aggregating all of your interviews and you're systematically reviewing them with all of the data that you've collected. So you can take audio, you can audio record your interviews and describe your interviews and actually do a content analysis, drop all of your data in a qualitative software, and this will help you identify new issues and make revisions and repilot. For our cognitive pre-testing interviews, we took detailed notes after each of the interviews. Like I said, we used the same structured guide with the probes. So we would summarize those notes according to the guide after the call. We would identify areas that needed additional pre-testing with discussion with the project team. And then we would review our feedback and we would make real-time adjustments within our survey platform so we could go on and do additional cognitive pre-testing. Next slide. So it really looked like this. We started with a draft survey. We went into cognitive interviews, and where we needed to, we reached out to our fantastic experts on our project who would help us navigate what changes we needed to make with our survey if we were really concerned about how we were asking a question or presenting a question to parents and families. Next slide. So here are a couple of results of just targeted things that we found or that we changed on our survey after doing cognitive interviewing. And I would say that there was not a question that went untouched in the entire initial survey. We got feedback everywhere. It was good. But there were a lot of changes. So like I said in the beginning, we really focused on flow and also plain language definitions. So here on the left side panel, you see some plain language definitions that we had for issues specifically associated with labor and delivery. And we asked parents, how they understood these medical terms, and almost always parents commented that they didn't really know all of the terms there, like meconium or shoulder dystocia, but with our plain language definitions, they were able to adequately determine whether or not it was something that they experienced or did not experience. So that was really helpful. I'd also mentioned that we did pre-test the survey with both parents, moms, dads, other partners, and we were really careful to also make sure the language was relevant to all different types of parents. And we feel pretty good about where we ended up with the plain language definitions. One of the other plain language definitions that came up, or jargony terms that came up that I think we were surprised about, was the word conceive. And it's possible, so we had a question, were any medications or medical procedures used to help you or your partner get pregnant? The language originally was conceive. And we noticed right away that parents, when they were answering this question, were actually thinking about induction. And it's not that they didn't know the word conceive, it's just that where the question was or how it was asked in the survey, that's where their mind went. So we made sure to change that question and just said like to get pregnant. And after we changed that language to be more plain language, we didn't have any problems with it. Next slide. And then we also asked families to look at a list of conditions and mark off if they had experience or if their child had been diagnosed or been told by a doctor that they had any of these conditions. And sure enough, with our true positive pre-testers, we had different variants of how you could explain or how you could term genetic disorder. So in the early iterations, we have this listed as genetic syndrome, and parents really did not identify with the word syndrome at all. So when we gave them this list, they would often just choose other. So we made sure to choose terminology that parents felt like they understood and felt like they could navigate easily. So that's a change that we made also pretty early on. Next. And then finally, well, not finally, but really the bread and butter of what our survey is about is newborn screening. We found that in our cognitive pre-tests that there is a broad diversity of experiences that parents are having, and particularly with our newborn screening parents that tested normal, the recall for the newborn screening was really difficult for them. Even parents who really truly did have a newborn, we tested within 2 years, but we did test parents who had, a 2-month-old, 3-month-old, 4-month-old. And very early on, we noticed that these tests were being confused with other tests that occur in the hospital, like APGAR, ASQ, bilirubin. I had one parent who was confused and thought that perhaps we were talking about genetic testing that occurred earlier. So we made sure to really try to describe what newborn screening is to orient all of the different survey takers that we have to what we're actually talking about so they can feel confident answering the questions that we lay out. So we made sure to say what the tests definitely weren't. And we also included pictures and a plain language definition of what each of the tests were and the expected timing of the tests. And that really helped parents understand if they even remembered the tests at all, which is really helpful. So we added a lot of explanatory text and a lot of pictures. Next slide, Brianne. And then one of the other things that we did is we added leading questions to better orient the respondents. So one of the other things we found, we asked about the hearing test and the congenital heart screen test. And originally we had this just as a yes/no question, like, did your child pass the newborn hearing screen, yes or no? And did your child pass the congenital heart screen, yes or no? And the majority of parents that we pre-tested selected yes for that. But in our interviews, what we find out is that they were selecting yes because no news is good news. And I think that, you know, that's common, but that is, we really wanted to make sure we were probing them to really truly answer no or I don't remember before we got into the newborn screening section for the blood spot, because it was really important for us to ensure that parents were confident that results were normal, abnormal, or you know, a follow-up test or a true positive, although there's not true positives in this group. But we really ended up doing a lot of leading questions to orient the respondent. And then we also added different response categories that were not yes, no, or unsure. They're scripted to say, I am unsure if, or I am confident they passed, I'm confident they failed. And these questions tested much better. Next. I'm running out of time, but the last thing that I'm going to review is we did also attempt to look at comparability. Our survey is actually going to be translated to Spanish, but we do have bilingual speakers who will also take the survey in English. So we tried to test what order some of our demographic questions should go into, specifically so we can capture race and ethnicity in a way that's culturally competent. So in our survey, we ended up putting ethnicity first and then asking race second to help the survey taker really understand how they wanted to identify. We found that when race is first, it's just a little bit different, and people will often select other, or they'll select something else and they're not sure quite how to proceed. And then we also customized our languages to the different sites that are going to actually be piloting our survey in the end. And then essentially with this pretester too, I just wanted to note that there is sometimes language translational issues that come up. So our pretester, who is predominantly a Spanish speaker, bilingual, but noted that miscarriage is not a word that like he really knew. And in order to ensure that we hope that folks do understand what we're asking about for miscarriage, we defined what that was. But it's just important to keep in mind that, you know, some words just like don't translate one-to-one from different languages. So next. I think these are just things that we think about. We did pretest a lot of our validated surveys, and some of those validated instruments tested better or worse than we would have expected. So it's something that we keep in mind. We didn't change validated surveys, but we did note that it is important to also test the validated surveys for thinking about analysis and interpretation. We also are in the middle of COVID-19, and a lot of families, particularly towards the end of our pretest, when we're talking about different stress events, or the way in which they take care of their child, they would ask, like, are you talking about before COVID or after COVID? And of course, we're talking about now, but people's perceptions and parenting behaviors have changed quite a bit in the last several months because of the pandemic. So it's something we'll have to keep in mind for our analysis and interpretation. And then our families were also very helpful for letting us know about the true burden of taking our surveys. So we revised our incentive structure accordingly to help hopefully increase a retention of our families and taking the surveys through the 2-year period, because it is a there is a decent amount of engagement that we need from our families for this study. So with that, I will acknowledge, there's additional resources. The slides will be posted, but these are very helpful resources for cognitive interviewing. And then next slide, I just want to say thank you to the project team. So again, Beth Tarini is the PI on this project. Brianne Miller, who is one of our wonderful host for the day, is also intimately involved in this project, as well as Ann Atkins. And they really keep everything going. So, and then also a special thanks to the families who generously took their time. Thank you.
Great, thank you so much, Norma-Jean. That was a fantastic presentation, and I will now pass the mic over to Lori for her presentation.
Okay. So thank you very much, Brianne, and that was very interesting, Norma-Jean. I'm took a lot of notes. May have you come speak to my graduate students. Thank you for this opportunity to present some of the work that we have been doing in the Heartland region, specifically around engaging the Spanish-speaking community. And I'm going to add just a little bit of a, I guess, a preview of another community with which we are engaging. And my deep dive into the methodology is going to certainly speak about the iterative process of our work, but also bring in the element around community engagement. And I do understand that the Genetic Alliance has offered other webinars around community engagement, but it's extraordinarily difficult for me to tease out sort of how do we even get to be able to conduct the interviews without talking about community engagement. So I just wanted to orient, I'm not exactly sure who all is comprised of our audience or comprising our audience today, so I just wanted to remind you about the Regional Genetics Networks, and the region that I represent is the Heartland, with a swath in the middle of the country, comprising 8 states, starting with North Dakota and going down to Arkansas, and then back up to Iowa. So we're in the middle of the country, and that will also be important when we talk about the communities with which we're working. Next slide, please. So the study that I was asked to speak about was what we have just labeled in our jargon internally as our Hispanic Access Project. Importantly, this project came from a clinical observation by one of our medical geneticists who was a participant in our regional genetics network. And this physician, this medical geneticist, had noted that in the state in which he practiced, which was Oklahoma, and that is a state with a very high Hispanic population, he noticed that he was not seeing as many Hispanic children as he would have expected. So he felt like the numbers were just too low given the population in Oklahoma. Of the patients that he did see who were Hispanic children, they were being referred later than they should have been. Now we see that across racial and ethnic groups, that there are always some children who are referred later than what we would like or under the ideal circumstances, but this was a pretty consistent pattern, which raised some red flags. What's going on is preventing these kids from, having that referral process started and being seen, within a reasonable time frame. And because they're being referred later, then that means that treatment or management in some cases was delayed. Certainly not in all cases, but in some. And so that led us to ask the question, what are the barriers to accessing genetic services for Spanish-speaking families in the Heartland region? Next slide. Our specific aims were to really begin to understand the knowledge base about genetics and genetic services within this population. How did members of the community know? How did they learn about these services? What factored into whether or not they would utilize the services? And then if they made it then to the genetics clinic, what were some issues that they encountered when they used genetic services? Next slide, please. So in our methods here, we actually began with some informal assessment. And I say we, but it was one individual. Our project coordinator for this project Marianne Kaufman. She's on the call today, and I have instructed her to please chime in during the Q&A session if I have omitted anything. But she began, we had the problem from the clinician, but she wanted to reach out and really kind of explore this issue a little bit more. And so she began to talk to some of the clinics that served this population, talk with some of the providers, begin to speak to some of the connections we had with family support networks and their Hispanic coordinators and parents that would work with other Spanish-speaking families. And what she found was that, yes, indeed, there is a problem, and that although this was informal, you know, it did affirm the need for further inquiry and for a full-on study. So we developed a study proposal then that did receive approval by the IRB, where I work at UAMS. And our study design was a descriptive interpretive study. We used, similar to what Norma presented, the semi-structured in-depth interview guide in order to get at those specific aims, to identify the knowledge, attitudes, beliefs, experience, et cetera, how they were accessing the services, what their experience was like. We selected 3 states. And we did this, well, I'll talk about that more in the next slide, but I'll just say that the 3 states of our 8 that we selected had population growth that exceeded the national average. And the study was conducted between May and November of 2014. Next slide, please. So how were the states identified? So we had the census data, but when you're working with minority communities, especially immigrant communities, you need to look at other data because the census data is really an underestimate, gross underestimate, I would say. And so what Marianne did was she went and looked at the birth rates of births to Hispanic mothers in all of our states. And so you had census data, but then she also had this other data source that combined said, okay, in our Heartland region, we have 4 states with high Hispanic population. Now, the 4 states that are selected are shown here on the screen: Oklahoma, Arkansas, Nebraska, and Kansas. And notably, all of these states have a meatpacking industry, poultry and beef primarily, and so they attract many of the immigrant workers. Most of the Hispanic folks in our region have immigrated from Mexico, although that's not uniform, but that's the majority. We ended up eliminating Arkansas as a state because there was another project. It was not exactly what we were doing, but it was also a HRSA-funded project where a population of Spanish-speaking families who have children with special health care needs, they were being interviewed at the same time that we were conducting our study. And so we felt like we needed to just leave Arkansas alone because there was some concern about just overlapping and creating confusion for some of the families. And so we just left Arkansas alone and went with Oklahoma, Nebraska, and Kansas. Next slide, please. So our recruitment targeted, of course, Spanish-speaking caregivers of children with some sort of condition requiring genetic services. So it could be an inherited condition, but it could also have been a chromosomal disorder such as Down syndrome. The potential interviewees were found, and then some of the contacts were made, but we had to rely on members of the community to help us find these individuals. So Marianne, you know, is a great networker and did a lot of footwork to find people within those states, within those communities who could help us identify the families. So she contacted the family support networks, such as OFN in Oklahoma and PTI in Nebraska. We reached out to genetic counselors in those states to try and Also ask them, did they have families that they, could connect us with? So it was an arduous, I would say, recruitment phase. It took a lot of effort to find families. And I will say that, next slide, please. I will say too that, when we're recruiting and we're trying to identify the families who we can speak with about their experience in genetic services, realize that there's some bias then in our recruitment, right? Because if we're wanting to understand the barriers to accessing genetic services, yet we're interviewing people who succeeded in accessing genetic services, that in and of itself, creates a little bit of a problem. Now, I think that in the end, our findings could stand, but we were aware of that problem. But you cannot, it's difficult, as you can imagine, when you're trying to recruit, to find people who should have received genetic services but didn't. How in the world would you go about finding those folks? So we were aware of that conundrum there. So once we had identified the participants, we then began to set up the interviews. And there are some important aspects in our methodology that I really want to tease out. First of all, when you're doing qualitative research, the interviewer, the researcher, becomes part of that experience. And so it was important for us to note that we were fortunate that we happened to have 3 Spanish-speaking staff, and 2 members of those staff were living in the United States at the time in our region and working for the Heartland Regional Genetics Network. One woman was from Mexico, and Marianne is from Peru. Their backgrounds also contributed, I think, to the success of the project. Marianne is a certified genetic counselor with public health experience, and the other woman had her MPH. They were both female, and most of our participants were female. And both of these women maintained close ties with the Hispanic community. So when Marianne and Anna set out to conduct the interviews, of course, we went to them. And when I say that, I don't mean that, Marianne and Anna drove from Arkansas and Oklahoma to Nebraska. Yes, they did that. But then once in Nebraska, they went to participants' homes, libraries, churches, clinics, family support network, conference rooms, whatever was a safe space where they could meet the family could get to them, and the family felt comfortable, which was also important. We also offered incentives through gift cards, which acknowledge the participants' time and expertise, and I think that's really important too. Especially when you're doing interviews, they take a long time, and when you're working with minority communities, this can be really helpful to them. So, and then the question guide that we developed was based on previous literature, excuse me, that informal exploration Marianne had conducted previously and clinicians' concerns. Of course, we used open-ended questions, a question guide, followed up with appropriate probes and extending the conversation as appropriate. And we continued, excuse me, the interviews until saturation was reached. And for those who may be new to qualitative research, the saturation is basically when you reach the point where you're not learning new information. And so one of the cues for an interviewer is, when you can begin to anticipate what the participant is going to say, then that's a cue that you're beginning to reach saturation. Of course, you don't know that for sure until you conduct an analysis of the transcripts. Next slide, please. So another important piece, I believe, in our study was that we, the third member of our staff that was actually out of the country at the time, she was also Peruvian. She can transcribe the recordings in Spanish. And that was so important to me because I thought, we have access to these three women, and we can not only conduct the interviews in Spanish, but then transcribe and do the analysis in Spanish. My hope was that then, Norma referred to that, sometimes, there just isn't a great way to express a term. We wanted to maintain the integrity of the data as best we could. And so that was just one way that we did that. Next slide, please. So in terms of the data analysis, these three native Spanish speakers then began to read the transcripts. Now, there was a fourth investigator we added to the mix. He was really the methodologist that guided the process. We, of course, jokingly call him our honorary Latina because after a year plus of analyzing data, he felt like he had a Spanish immersion classes with these ladies. But he did not speak Spanish, but he is an expert in health communications and qualitative research, and so he would guide their work. He would ask the questions to get them to, respond and think about, we're making a claim. Does the data really support that claim? Now, another aspect of qualitative research that's really important is that this is an iterative interpretive process. And so when you go, your initial read of the transcripts, if you are the interviewer, many times, at least my experience, when I do an initial read, I remember the interview, and certain pieces of content, will emerge that, are common across my interviews, but I'm really still pretty engaged with the participant, even at that point, even when I'm reading the transcript for the first time. After I have sort of taken my notes and looked at what emerged for me, what really spoke to me, then I want to take those pieces and see, okay, how can I organize the content, the common content from the transcripts into themes? And I'll do that. And then the group will come back together. And this is what happened over and over again. The themes, we would stake claim on certain themes, but then there would be a lot of arguing and a lot of discussion around, is that really what this data, is saying? And we would read again. And eventually, over some time, the person who has conducted the interviews, if they are also conducting the data analysis, they begin to distance themselves a little bit from the process. And so the way I describe it to my graduate students is the data begins to just scream at you off the page. It becomes more objective, and you can really begin to see new messages sometimes in that data. And you repeat this until there is some consensus. In this particular study, there were also external factors that influenced, I think, the interpretation, and we had to be extraordinarily careful, and it took us extra time, quite frankly, because these women still lived in this community. Mary Ann was working in Hispanic churches and with Hispanic community in another part of her life. And so all of that, is influencing the interpretation, but we had to keep coming back to, do the data support the claims that we have made? And Brianne, I'm cognizant of time here. I'll try to wrap up as quickly as I can. The next step was certainly to validate our findings. And so we took our findings back to the community. So what does that mean? What does that look like? We did not take our findings back to the people we interviewed. We didn't have that luxury, but we did take our findings back to a board, an advisory group that we had formed along the way. So what had happened is, as we began this project and began the interviews, we realized, actually Mary Ann realized, we really needed a group of advisors who were from not just from the Hispanic community, but other sectors, from other sectors with which that community engaged. And so an advisory group was formed. And so we took these findings back to that advisory group and asked them, does this make sense? Does this resonate? Is this similar to what you've seen and what your experience is? Next slide, please. And Brianne, I may have, I should be on the implementation slide, slide 12. So, so we took it back to this board. And then what the board did, they discussed this in light of their own experiences and knowledge. And then they converted the findings into 13 actionable recommendations. They then took those recommendations and began to prioritize them. We had to prioritize those based on what they viewed as most important, but also what is feasible for us to implement through the Heartland Regional Genetics Network. What could we afford? What did we have time to do? What did we have the staff and manpower to do? And then we continue to take it back to the board. So we will implement an activity, and I'll tell you in just a couple moments, a current activity where we continue this cycle of implement, evaluate, check back, implement, evaluate, check back. That example, they wanted to start, one of the priorities was community education. And they said, and I'm making this very short, very brief, but they said that one of the best ways to do this is through videos. Everyone seems to have a smartphone. And so if you can put something on YouTube and drive traffic to that, that would be a good method for education. So they helped us to develop what type of education. We did that, but at every step of developing the videos, the step of the script, the step of the artwork, the step of reviewing the PowerPoint slides before the animation was added, every single step was taken back to the community to look at. And so we continue that process. Just because we did our study, we published our study, we don't just wipe our hands and say we're finished. Now, I am going to, because of time, I'm just going to, really run through this quickly, but we've engaged with another community of Pacific Islanders that also live in our region, the Marshallese community, and using some of these same approaches. However, we have encountered new challenges, and they're depicted on this slide, and I think that's because of time today, I'm not going to go through all of that, but I'd be happy to answer any questions about this. There are many methods we're able to use that's similar to what we used in the Hispanic community, but we had many new considerations. I would say, though, that a common theme across those communities is you have to have someone from the community who understands the work that you're trying to do and can help you reach the community. You have to really take a learner position and be humble and set your ego aside and do a lot of listening. With that, because of time, I will say thank you and turn it back to Brianne.
Great, thank you so much, Lori. That was another fantastic presentation. And with that, we will open up the the Q&A section of our webinar today. A reminder, if you have any questions for Lori or Norma-Jean, please put them in the chat box and we will get them to them. So the first question we have is for both of you, and whoever wants to go first can jump right in, but I think we always kind of go into these interviews expecting to have certain outcomes, and I think a lot of times we're surprised by what we do learn or find from these interviews. So what most surprised you when you were doing these interviews?
I can take that.
Yeah, go ahead.
Okay, I'll go first. Lori, you'll get the next one first, if it's to both of us. Okay. What surprised? So I think that, and I think if Brianne wants to chime in on this too, she can, because she was a part of this process also. But I think what was surprising to us is I don't actually think that we thought we were going to be in pre-testing as long as we were. The newborn screening testing questions and the newborn screening communication questions really required a lot of revision on our part. We knew that people's newborn screening experiences were going to be different, and we definitely anticipated that parents who received or perhaps didn't receive, we also knew that parents wouldn't receive newborn screening results if they were normal. I don't think we expected in the end how much our newborn screening testing section really ended up feeling like a primer on what newborn screening is and almost an education tool in order to prime our research. In this case, it was our cognitive interview participants, but for our future survey participants for the study, to have them really understand what we were talking about before we even got into the newborn screening questions. So I think just the length of time that it took us to really revise the survey, I think was unexpected for the entire project team, though to everyone's credit, we took the time to do that. So I think that is the biggest surprise. Brianne, do you have anything, or Lori?
Yeah, I completely agree. I think that was something we weren't really expecting. We kind of went in thinking, oh, we can just ask them what their experience with newborn screening was, not thinking that we needed to prime them on what it was prior. So yeah, I think that's great.
Yeah, and sometimes this is where it's helpful to have people that you do know review the survey, because sometimes you talk with somebody and I think that some people are sometimes more willing to say, like, I had no idea what you were talking about. And that's how we found out pretty early on that, like, even our normals and people who, you know, when we're reaching out to our contacts, we also know we're introducing bias because we do know those people and they're in our network. But a lot of them just completely, the newborn screening part was completely lost on them. So yeah, I'll hand it to Lori.
Well, I mean, my comment on that is we had a couple surprises. One was the time it took to analyze the data. That was partially because our methodologist was not Spanish speaking, and so it took a long time, but it was also partially because the primary analysts were from the Hispanic community. There was a lot to tease out, and there was a lot of data. And so that iterative cycle of just making sure you go back and, you know, you think one thing, but, you know, you think you have a theme or a claim that you're making, but do your data support that? And just constantly going back. That took so much longer than what we ever imagined it would.
Great, thank you so much for sharing that. Lori, I am wondering if you want to share a little bit more about the process with your interviews specifically, and how important it was for you to go to your interviewees' homes and really adapt to them for that process to be really informative and beneficial for you.
I would be happy to, and I feel guilty because I feel like Mary Ann should be giving this talk. She did the work. So I'm going to be telling you her story, and she can chime in here. But their experience was actually quite profound. Being invited into people's homes, culturally, there was a lot that had to take place first in terms of food and drink. They found themselves, you know, as they're beginning to learn people's stories. It's incredibly difficult to be just a researcher only when you are a genetic counselor too, and you hear stories and they don't understand some of the education and they need resources. So those were some of the biggest challenges. These interviews ranged anywhere from 2 hours to 4. This is incredibly time intensive on their part, but I don't think that we would have had the richness of the data and the family stories and the openness to share if we didn't have gone, went to their homes mostly. Most of the interviews were conducted in homes, drank the tea they offered, ate the food they offered, built rapport, and listened to their stories. This is for most of the families interviewed, Marianne, correct me if I'm wrong, this was the first time they really could tell their whole story, which was an unintended consequence of the research then, was that was very therapeutic for them, when of course we didn't set out for that to happen, but that happened.
Yeah, I would agree. Every home was a different experience. And Anna and I, my colleague, we moved into those homes. It was very humbling. They did have a story to share, but also we had to adapt many times. If there was a male present in the room, Anna was younger, right, in her 30s, and I'm older. We realized that I needed to conduct the interview because the man usually would not pay much attention to her. On the other hand, it was a very young woman. She would relay much more to Anna than to me. And so Anna took the lead in the interviews, just depended. So we learned to be very flexible, very humbling. We also learned to act on our feet pretty quickly when they couldn't understand a question. And so as we progressed in our interviews, we did have to modify the question some, and that was more surprising because I thought I had done a lot of the, what you all call the cognitive pre-testing, but still it was always a surprise. So we had to adapt to the culture and their graciousness and hospitality of wanting to share their story and wanted to share food with us.
Fantastic. Thank you so much for jumping in and sharing that. I appreciate it. And we're almost out of time, so I will ask one more quick question to Norma-Jean. We selected our pre-testers from different newborn screening groups, and I'm just wondering if you could talk a little bit about how important it was for the development of the survey to have pre-tested it with both normals and true positives and the few false positives we got, and the differences that those groups showed us.
I'm getting a warning, I'm muted. So it was really important because I think we started the survey with the normal group, and I think there were a lot of assumptions that we made about how much people knew in the normal group to start off with. And then when we first started pre-testing with the false positive and the true positives, we were really understanding the much like richer experience that happens, and particularly your true positives really are remembering the experience quite a bit more, and we could tell from gleaning some of their information from what occurred in the hospital, we're able to basically actually go back to some of our normal pretesters and I think ask more targeted questions about what really happened in the hospital, because I think particularly with the normal results, I really think that there was this positive response bias that we missed in the beginning, because people would say like, yes, I knew this, yes, I knew this, yes, I knew this. And when you're going through and reviewing the survey with them, unless we had targeted questions, like they moved on with like a lot of confidence. So I think doing the false positives and the true positives also helped us refine how we were asking questions of the normal group to actually ensure that we were really getting the appropriate information. And then, like I said, we only had a handful of false positives, so we had to supplement with the true positives. And really the last part of our pretest, we're really focused on this newborn screening communication. And we really found too that the communication can really diverge. So we had to accommodate that in our questions. So I think that was really important. I think that we're finding now is that because we didn't have enough pretests with our false positives, we're being actually really mindful and really in reviewing our surveys that we have gone live to make sure we're actually also capturing the experiences of our false positive group. And I think we're more mindful to that too, knowing that we didn't get to capture that group in its entirety. But I think we ended up with a better survey and fielded a better survey because we had this, or tried to capture a diversity of groups to pretest their survey to begin with. But that's kind of one of the things I thought is I really wish we actually had more false positives now that we've moved forward with the survey.
Great, thank you so much for going a little more into that. And I just want to be conscious of everyone's time. So thank you, Norma-Jean and Lori, so much for your presentations, and to everyone for tuning in today.